Good morning, everyone. We are the Gut Group, and our project focuses on how our gut microbiome composition is associated with the manifestation of eczema in infants. This is our presentation content, and I will kick off with our project introduction. Eczema is usually the first manifestation of an atopic diathesis, which is a predisposition to develop either one or more of hay fever, allergic rhinitis, bronchial asthma, or atopic dermatitis, which can greatly influence health status. For children with eczema, 80% eventually develop allergic rhinitis or asthma within 5 years of diagnosis. So what is eczema? Eczema commonly begins in infancy and is classified as a chronic inflammatory disorder of the skin. It is more common in affluent societies, and 60% of cases affect children in their first year of life, with 30% prevalence in infants, hence why this study focuses on infants. For some, the condition can even persist into adulthood. To date, although the co-evolution of our microbiota and immune system remains unknown, it is clear that the gut microbiota plays an important role in regulating the innate and adaptive immunity. The purpose of our chosen research paper is to compare gut microbiota of healthy infants against infants who experienced eczema during their first year of life. Moving on to their study design, high-throughput sequencing was carried out for V3-V4 hypervariable regions of the 16S rRNA gene from gut fecal material to characterize and compare between healthy and eczematous infants' gut microbiota. Their workflow includes sample collection, DNA extraction, PCR and viral sequencing, bioinformatics, and statistical analysis before finally uploading their sequence read accession number onto GenBank. For sample control, a case control study was carried out, and there were a total of 101 study subjects. Stool samples were collected at 12 to 13 months of age, with 50 and 51 case and control samples respectively. Case samples were from infants who developed eczema within the first 12 months, while control samples were from healthy infants who had not developed eczema within the first 12 months. The rest of the workflow made use of the various techniques and protocol as stated. I will now pass the time on to Hamizan to talk more about the study results.
Thank you, Huilin. Moving on, the procedures employed by the researchers as shared earlier can be summarized in this flowchart, and I'll be sharing with you the results from the bioinformatics and statistical analysis. MOTHER was used to obtain the operational taxonomic unit, or OTU in short, from the sequences generated. In total, 12,386 OTUs were obtained at 97% similarity. They also did a goods coverage analysis, estimating to be more than 98% for both groups, meaning that sufficient sequencing depth was done. The microbial composition of both the groups were illustrated in the Venn diagram on the left. If we examine the non-overlapping regions of OTUs, there seems to be a large difference in the unique OTUs in eczema and healthy infants, but they are not statistically significant for now. Then, what did the researchers do? They examined for the bacterial richness and diversity utilizing the metric or tool as shown, and all showed that they were not statistically different. If this is the case, then how are they going to progress further to find a conclusion? They proceeded on to adopt another statistical methodology called metastats to detect taxa-abundance of differentially abundant functional and taxonomic groups. And this is a comparison of eczema and healthy infants in terms of phyla. And take note that the inner circle shows eczema infants while the outer circle shows healthy infants. And they discovered a total of 10 phyla in the samples, but Firmicutes, Proteobacteria, Bacteroidetes, and Actinobacteria are the major ones highlighted here. But there was no significant difference at phyla level. So far, I have covered the data concerning the characteristics of samples from both healthy and eczema infants, and also the differences in bacterial phyla, and the rest will be discussed by Shermin.
Microbiota abundance between the two groups of infants at the family level. A total of 83 bacterial families were identified from the fecal samples, 12 of which were unique to infants with eczema, and 14 of them were unique to healthy infants. The two groups shared 57 families in common. 10 of the most abundant families that the two groups shared accounted for more than 92.7% of the total sequence. Only 8 of these families, as highlighted in the red boxes, had a statistical difference in abundance between the two groups. 2 families were also identified as biomarkers of eczema, as highlighted in the green boxes. Next, at the genus level of comparison, 170 bacterial genera were identified. Infants with eczema had 136 bacterial genera, of which 34 were unique to them, while healthy infants had 143 bacterial genera, of which 27 were unique to them. The proportion of all unique genera accounted for lower than 0.01%, showing no significant difference between healthy infants and infants with eczema. A total of 50 genera were significantly different between the two groups. The 11 most abundant genera accounted for more than 1% of the total DNA in both groups. They accounted for 78.1% and 80.4% of the total sequence in healthy infants and infants with eczema, respectively. 50 genera had also been identified to be significantly different. 41 of them were lesser in abundance, while the other 9 came from part of the 11 identified previously to be the most abundant, with the exception of Megamonas and Bacteroides. Out of these 9 genera, 4 were consistently enriched in healthy infants, while the other 5 were consistently enriched in infants with eczema. Particularly, Clostridium fortini has been identified as a biomarker for eczema. This diagram summarizes the relationship between all 170 identified bacterial genera. Next, Evelyn will be going through discussions.
Thank you, Charmaine. In summary, their microbial composition analysis revealed that the taxonomic composition did not show significant difference. However, there was significant difference between taxonomic abundance between healthy and eczema infants. Previously, as mentioned, there were enrichment in genus found between healthy or eczema infants. For these genus, they managed to find specifically 13 species that are enriched and abundance in eczema or healthy infants. Those highlighted in red for eczema infants and green for healthy infants will be mentioned in the following slides. Firstly, Escherichia shigella genus, a member of Enterobacteriaceae family, was enriched in eczema infants, which was consistent with other studies. There was also an increase in Ruminococcus guavus in eczema infants, which is known to be involved in inflammation or atopy. Notably, Ruminococcus guavus is also predominantly found in Crohn's disease patients and is associated with colonization of Clostridium difficile, a major pathogen responsible for antibiotic-associated diarrhea, suggesting that the higher abundance of Ruminococcus guavus could predispose eczema infants to reduce the risk of Crohn's disease and antibiotic-associated diarrhea. Furthermore, they found an enrichment in Akkermansia mucin, which is a mucin-degrading bacterium in intestine, to reduce the integrity of intestinal barrier, which can cause an increase in uptake of allergen proteins, suggesting enrichment in Akkermansia mucin could contribute to eczema in infants. Next, for the healthy infants, they found enrichment of Bifidobacterium and Bifidobacterium longum, both of which was proven to reduce the risk of eczema in infants in other studies. Also, Bacteroides fragilis was enriched in healthy infants, which was expected since it was reported to increase in healthy infants to correct systemic T-cell deficiency and mediate establishment of Th1, Th2 balance for infants. The lower proportion of Bacteroides fragilis in eczema infants thus might indicate an imbalanced Th1, Th2, which contribute to allergy-like eczema. Furthermore, they also found an enrichment in Streptococcus salivarius, which is associated to have anti-inflammatory properties. Next, Hei will finish off with the critiques of the paper.
I will now be presenting on some points of critique we have for the article. Firstly, case control studies have disadvantages which could limit the value of the findings. These studies only establish correlations rather than causation, which could limit the usefulness of the data for things like finding ways to prevent a disease, as we do not know the root cause. It can also be challenging to apply insights from these results to individuals of different backgrounds. Thirdly, subjects in this study are categorized only based on whether or not they developed eczema. However, eczema can differ in severity, which could affect gut microbiota but cannot be accounted for in such studies. Next, it was mentioned that the researchers invited 150 of the infants to be included in the study without explaining the criteria for invitations. The selection process could possibly affect the quality of the results, such as by leaving out individuals with significant results. In addition, there may also be characteristics shared by infants whose mothers agreed to the study, but not shared by those who did not agree. For example, mothers who agreed may be more health conscious in the way they care for their infants, which in turn affect the infant's microbiota. While it is a given that only those who gave consent can participate, the researchers should look into potential ways this could affect the quality of results. Lastly, the results were based on a one-off collection of infant stool samples. However, as we know, our microbiota has a dynamic nature, especially so for infants whose microbiota is less stable than those of adults. Thus, samples taken at different time points may be more representative in establishing associations with eczema. Next, we did research on other findings on this topic in the field, and there seems to be contradictions. For example, our paper reported no significant differences in gut bacterial diversity between healthy babies and those with eczema. However, 2 papers have suggested reduced diversity. Our paper also concluded that differences in composition is not significant between the 2 groups, but one paper reports associations for microbiota composition in babies with eczema. As with many other scientific research papers, there are bound to be conflicting results in the field, especially when looking at associations. There are also numerous factors that could possibly affect results. While conflicting findings do not necessarily invalidate the results, it calls for further research and deeper evaluation of the research design. This would give rise to better quality studies with more reliable results to give us a clearer understanding of these conditions in the future. We've come to the end of our presentation. Thank you.